All right, thank you, Murph, and thank you, everyone. It's really a pleasure to be here. Yeah, I mean, I think it's been really interesting set of semester. I certainly enjoyed all of them, and I hope you also enjoyed the class as well. As Murph mentioned, my yeah, I am industrial engineer by training. My specialization area is in research, and I have been working on problems that typically come out of healthcare operations, and emergency response systems for a number of years. But I had not done any work in responding to diseases like COVID, where there's this viral infection. It's a type of problem that requires different types of models. So I had not really worked on those types of problems, but of course, this past summer, just like you all did, that we had an interesting summer, and suddenly all of us started thinking about coronavirus, and whenever like your world around you changes, you come up with these new ideas, new research ideas. So what I'm going to be talking about today, actually, let me go ahead and share my screen. Is something I have worked on over the summer with one of my former PhD students, Alex Mills, who is in Baruch College in New York, in the business school over there. And so I'm going to explain the basic motivation behind it, but basically we were chatting about this whole problem with coronavirus testing, and we thought about what kind of things that we can work on. And what we ended up doing was something relatively, I think, simple. So the idea was to consider a simple mathematical model with the idea of maybe generating insights into what kind of testing strategy is optimal. And I thought that I could present at least part of this work because it's very relevant to, of course, COVID-19. I think it will give you a brief introduction to how you can use optimism and in a way that you can maybe generate some policy insights. So hopefully I will try to simplify things so that it won't be too difficult to understand it, even if you haven't taken any courses. Let's say, and I know the main problem that we were interested in was this lack of testing capacity. So some of these articles are not very recent. So just to give you some background, so we have written this paper back in July, and even though the problem is still continuing, the testing, the limited availability of tests was even a significant issue back then. So every day you look at the news articles that you will see a few articles which were discussing like, okay, how limited test capacities and how it is impeding the response to the disease. And one of the things, okay, it wasn't just a problem in the United States. It was in other countries as well. So these are just some headlines from UK. Obviously, I mean, if you remember, back in February in the US, there were some issues that delayed even the approval of the tests, and then after, it quite some time for the testing capacity to increase levels that were really remotely desirable. Now, at the time, so given that the tests were extremely limited, it was necessary to come up with some sort of prioritization. So who should really be tested when you have limited availability of these tests? And CDC had these guidelines that outlined who should be tested. And this was back in March. And still of prioritization place because there are some delays to tests and so on. So basically, the idea was this. So depending on your clinical features and your epidemiologic risk, that you would get different types of priorities. So at the top of the were people who had fever or some signs and symptoms of lower respiratory illness, and also an epidemiologic risk, basically, maybe like a healthcare worker who has had close contact with a positive patient. Those people would be at the top of the priority list. And the second in the list would be, again, people who have the clinical features of COVID, require hospitalization. Maybe the epidemiologic risk was not person was in close contact with a COVID positive person, but maybe this person has traveled to one of the countries who had a significant number of COVID positive cases. And the third in the list was maybe this person did not have any increased epidemiological risk, but the person has had some lower respiratory illness symptoms, and the patient requires hospitalization, and some of the alternative possibilities like the flu had been ruled out. So that was the kind of the list. So if you look at this prioritization list, what you can see is that the priority was really given to people who really had a high probability of having COVID coronavirus in the first place. So the people who were most likely to have it were getting the top priority. And this was something that we were thinking with Alex, whether or not makes sense. If the person is already very likely to have the disease and you are going to hospitalize the patient anyway, why maybe you should really use your limited tests to other individuals. And that was the starting point, and we thought that maybe we can do some sort of mathematical modeling to understand this issue a little bit better. And around that time, in July, people also have started talking about the pool. So this was something we actually already knew, and we were planning to look into it. But as we were working on this problem, US also has started considering this pool testing as maybe a national strategy. Actually, there was a statement from Archie in July 1st, basically pointing that out, that this is pool testing. This is Professor Fraser mentioned last week, and I know you're familiar with it, but it's essentially the idea of putting the samples from several individuals together and testing there. If the pooled sample ends up being negative, you rule out essentially each individual who had sampled as being positive. But if the pooled sample ends up being positive, you don't really know which one might actually have been positive, so you need to test them individually. So we also wanted to consider that as a possible strategy, like how, if you're using pool testing, how would that impact the way that you would use your limited testing capacity? But then in August, though, people have started questioning the wisdom of using pool testing in the US, because that the idea was that this pool testing strategy only works when you have a vast majority of tests are negative, because obviously if too many of your samples are positive and you are doing pool testing, the test will very likely turn out to be positive. So you have to then individually test these as well. So it won't really work if you have a high percentage of your population is positive. So I guess that might have been the reason why it's not more widely used these days. But obviously there are in some places we know, for instance, it's being used at Cornell and in other places. Okay, so throughout the summer and even now that the availability of tests is increasing, we are getting more and more capacity every day. But with the increase of the capacity, the demand for these tests also increase. So what ends up being is that we still have tests that are only limited available in comparison with the demand that we are seeing. And also, we are also getting into these situations where to open up the economy more, to essentially get back to normal life, pre-pandemic life as quickly as possible, different things are happening. For instance, that to open up sports, athletics, people are doing like before, for instance, that they are testing the whole doing group testing to all the players that who will be competing and ruling out any COVID positive case, and then the game proceeds. And there are also other events that are happening as well. Like we know, for instance, that in the widely reported White House meeting where the coronavirus likely had spread, that people were actually tested for COVID. And so this is an event that a certain number of individuals have attended, and they went through these tests, and then people who ruled out are actually admitted to the event. So, and these things are being considered, like for instance, before flights, the passengers in some airlines are actually requesting their passengers to go tests. So increasing the demand for these tests seems to be increasing, and in comparison, the capacity of the testing capacity is still not at desirable levels. All right. So just to again remind you what the research questions here are. So given that the lack of testing capacity has persistently been one of the main problems of dealing with COVID-19 in the United States, we were basically bringing up this question of, okay, so given that we are dealing with this limited testing capacity, who should be tested? And on top of that, if pooling is an option, how does that change the answer to this question of how we should use this limited testing capacity? And so this is we are mainly motivated by, I mean, the research really started with obviously COVID-19 pandemic, but this is a question that is always going to be relevant. So I hope the next pandemic is really far away, but we obviously need to get prepared for these events, right? So you never know what's going to happen, and research is typically, well, I shouldn't really say typically, but a good chunk of research is also about uh, thinking about future possibilities and planning for them and developing for them. And in fact, that usually makes more sense, maybe at least for certain types of problems, because research takes a lot of time. So we need to, even if the analysis that you do may not really be immediately relevant to today's world, COVID-19, what we learn from here and the research that we are going to be doing, motivated by problems of this pandemic, will hopefully help us prepare for the future. So this is kind of like this is, I think, the right way of thinking about this research. So what basically the specifically about COVID-19, but more about how you would use your limited testing capacity in situations of this sort. Okay, what is our approach? So the idea here is we formulate this problem, what we call a stylized optimization model with heterogeneous patients. I'm going to explain what I mean by these. So by stylized, our is not really to model the pandemic in a very, very realistic manner, in a way that, oh, okay, you would say that, okay, this is exactly what is happening. Because if you think about this, if you really attempt to come up with a very realistic model of this situation, it's extremely complicated. And an extremely complicated problem, uh, it may, it's very unlikely that it will be you. So you can't really analyze it mathematically, and you can't really gain any insight into the research question that you wanted to investigate. So it's a very typical approach. You make simplifications in a way that captures the main features of the problem, and then from that problem you generate insights into the problem as it exists in real life. Okay. Um, of course, then always you need to approach your findings with a grain of salt, because that you have to keep in mind that you are dealing with simplified assumptions here, right? And so the heterogeneous patients, I think it will be a little bit clearer later on. But what I mean by that is patients who are really coming from all different sorts of risk groups. So there could be people who are who are in contact with COVID positive people, who might have traveled outside the country, risky countries, and other people who just have maybe the clinical symptoms but not have any epidemiological increased risk. So okay, that's the approach that we're going to be using. So we're going to develop this stylized optimal model, and we prove results, mathematical results, on the structure of the optimal solution to this problem, and we then guidelines based on the solution that can inform policymakers and operations managers. Okay, so that's that. Okay, so let's start with the first question. So who to test? So I'm going to start with a simple example. So just to really show you how simple the idea here is. Suppose that we have 4 individuals, A, B, C, and D, and these are their probabilities of having COVID. Let's say, and this is before they have any tests. Let's say that somebody told you, okay, we have these 4 individuals, and we know that individual A has 0.9 probability of having COVID, B has 0.8, C has 0.7, and D has 0.6. And we have test kits only. Who should get them? Okay, so that's the question. What do you think? Purely from if you have no math based on from your intuitive understanding of this problem, who would you test? Any thoughts? I think you're not probably doing these very interactive. Okay, so I got a few responses. Excellent. Okay. Why can't I see those? Because I'm in presentation mode. Just a second. I can't really see. Murph, can you tell me what the?
Yeah, so we're getting a lot of A, C, and D, but I think nobody wants
B?
to say B. A lot of people are saying C and D.
Okay.
Yvonne says, since 90% of A is likely to be infected, we can assume they're all infected, A and B, so we should go for C and D.
Okay. I mean, I think they're excellent answers, because I think like maybe yeah, B was unlucky because it's like the probability was perceived somewhat maybe in the middle, and so 0.7, 0.6. So actually, I think it looks like everyone tried to come up with some assessment of these probabilities along with maybe the potential benefits of them, and that's, I think, the right idea. But when you think a little bit more deeply about this question and what should the answer depend on, maybe one important issue is the misclassification probabilities, right? So as we know that these tests are not perfect, so they end up misclassifying a lot of people. They say that it's positive, but in fact, the patient is negative, or the test says it's negative, and the patient ends up being positive, right? And also these two additional questions: how valuable is it to correctly identify a positive case versus a negative case? Okay, and also how damaging is it to classify a positive case versus a negative case? So I don't know the answer to these questions. I mean, and I don't think anybody does. You can see that really extremely relevant to this question, right? How value identifying a positive case over a negative case, and don't compare with um, incorrectly classifying a positive case with a negative case. Okay, I'll come back to these questions a little bit later on, but I think that this is the way that we approach this problem, that it's important to take into account misclassification probabilities, the potential value of identifying positive and negative cases, and maybe making incorrect classifications. So that example a little bit later, but here essentially we're thinking, suppose that we're going to just generalize things a little bit. Suppose that we have some n samples, and suppose that the ith one of these have probability pi of having the infection, and suppose that we have only m tests, and the false positive rate is alpha. So alpha is the probability that the person is given is positive, but the decision is incorrect, and false negative rate is beta. And there are 5 possible outcomes for each sample, and essentially we get rewards for true positive and true negative classifications. These we will denote by little r, and the subscripts will be true positive, true, or true negative, right? And then we will have these costs. So here, when I say rewards and costs, obviously talking about dollars, okay? And we're talking about some sort of utility of identifying these individuals correctly or making incorrect determination about their status, right? Positive will be CFP and positive is C sub N. And then we can also have people who are not tested. So essentially, we can start with this. If you're not a person, essentially the net reward for those people will be 0, right? And you can then maybe normalizing that, you can maybe try to assign the rewards and costs accordingly. And okay, so let's go a little bit further. All right, so this is the mathematical notation that we're going to be using, and based on that, we define the expected reward and expected reward for people who are actually COVID positive, and expected reward for people who are COVID negative. And I don't know how many of you are familiar with the concept of a value of a random, so I'm not going to spend a lot of time, but you can see that the way that we calculated this to be essentially 1 minus beta is the probability that the positive patient, positive COVID positive person is correctly classified as positive, right? And beta is the probability that the person is incorrectly classified as negative. So essentially, we are multiplying these rewards and costs with respect to the corresponding probabilities. And so essentially, we are weighting these measures. So that's the meaning of expected value. For a patient, for a patient, positive patient who is tested, the expected reward has this particular expression. And
Trickers is a different level. Shit, this shit's poking. Poking, boy. Wish my mic was.
Yeah. All right. That's what I was going to say. Okay, thank you. All right. So, and similarly, we have the expected reward for patient who is actually negative, and the expected reward for testing that patient has this particular expression. So that's again the expected value of expected reward for testing a negative patient. And then using these, if you then consider this particular patient whose prior probability of having COVID is pi, pi of pi will give you the expected reward for testing that particular patient. Okay, so we have this mathematical way of expressing this expected net reward for each patient. And then finally, we have this basic model. So hopefully this will be, I think this will be the most mathematical slide that I'm going to be showing you. So this is what we call an integer program. And so if you look at here, we have what we call the objective function. What we want to do is maximize this, okay? Here, xi is called a decision variable. And it's a decision variable that can take on values of either 0 or 1, okay? So it takes a value of 1 if we test individual I. So that's the interpretation. And it takes a value of 0 if individual I is not tested. So you can see then that if you sum up xi of pi of pi's over all the patients, 1 through n, then you will get your expected total reward, okay? And the total number of people that you will be testing needs to be less than or equal to m, because that is your testing capacity, okay? So that is what we call integer program. is called integer because for the reason that the decision variables xi's are allowed to be integers of 0 or only. Okay. So there are ways of solving this problem, but what we want to do really is not really numerically solve this, but analyze this particular optimization problem and maybe characterize the optimal solution. Okay, so but before we give these general results, let's come back to this example that we have looked at before. And suppose that, okay, so we have these probabilities. And let's make some assumptions about the model parameters. Let's say that alpha is equal to 0.01. So if you remember, alpha is the false positive rate. So that's the probability that a person who is actually positive is incorrectly classified as negative. And beta is the false negative rate. So that's the 0.05. That's the probability that the person who is actually negative is sorry, did I make that correctly? Alpha is, yeah, false negative rate is beta. Beta is the person who is actually, sorry, I think I messed this up. So alpha is, yeah, beta is the probability that the person who is actually positive is incorrectly classified as negative, right? So that's probability 0.05. And alpha is the person who is negative is actually incorrectly as positive. And so especially when these tests first developed, there are different types of tests, and this alpha was typically somewhat small, close to 0, but the beta had really a wide range of possible values, and the numbers proposed were ranging from 0.01 to all the way like even 0.29, and the probabilities could be quite high. But I just made these numbers up, and then we also need to say something about the rewards and costs. So again, as I said before, nobody knows what parameters are, but you can make some assumptions about which ones are likely to be higher than the others. So that's how I kind of set these rewards up. So like I just normalize one, like suppose that the reward of correct, well, true identity of a negative individual, if we set that to 1, maybe we obviously a correct identification of a patient will have to be probably much more valuable. So maybe I said that, maybe let's say that it's 5 times as much. And the costs, let's say that, okay, let's make that false positive is 2. So that is you're telling this person that you are positive. So this person will have to quarantine for a while. So obviously that's not good. But hopefully that person, well, that person will not really be impacting other individuals. In contrast, like if you classify a person as negative, though, that's really significant because you're saying that a person is positive, but you're saying that, oh, okay, you're not positive, so this person just can go their way and spread this virus to other individuals. So that we will think that should be something like even larger than truly identifying a positive people. But I completely admit that these are numbers I made up, and we don't know what they are, okay? But let's assume that that is the case. Then we can compute all these expected values that I showed you earlier. The expected value for testing a positive individual, and the expected value for testing a negative individual. So we find here that the value is 4 for testing individual, and the value is 0.97 for testing a negative individual. And then we can compute for each one of these 4 people in this population the expected rewards, okay? So this is what will turn out, right? It will, for A, the reward is something close to 3.7. For B, it's 3.39. For C, it's 3.09. For 2.79, okay? So let me ask you now, how would you allocate these 2 tests to these 4 individuals? When maybe you think about the optimization problem that I showed you earlier. Remember, the goal is to maximize the total, okay? In this case, and that we don't really have much time, let me just proceed. Because you are really trying to maximize the total expected reward, it will to pick the one is as the largest expected reward, then the second largest, right? Because if you add those 2 numbers up, you will get the largest expected reward for this population. So that's what the optimization problem will tell you. Now let's consider a different scenario, okay? This time, let's say, again, remember this scenario, we keep the rewards, let's say, the same, but consider this possibility that beta, false positive rate, is actually higher, right? So imagine one of the possibilities that when we had the first test, that let's make it 0.25. Now, maybe in today's conditions, this might be a little bit unrealistic, okay? I just cheated at this a little bit. But, you know, I could have played with the rewards and costs as well, just to create the scenario that I want. Because we don't even know what these rewards and costs are to begin with, right? But if you compute the expected reward to people and the expected reward to people here, now we will find 0.4 and 0.97, okay? And by the way, that the false positive rates when for these fast tests actually could be quite high, and they were even higher again back when back in summer when fever tests and the testing was even more of an issue. Okay, so with this expected reward for positive and negative people, we can compute the expected reward for each individual in the population again. And this is what we would find. For A through D, now the rewards are going from 0.457, 0.514, 0.571, and 0.628. Now, how would you allocate these tests now? And now you would actually allocate tests so that C and D are going to get the expected reward. And so if you actually think about this simplified scenario, if you had given your tests to A and B, the 2 individuals who had the higher probability of having the test, and which is basically pretty much what mostly I think CDC was advocating, you will be allocating your tests so that you will be minimizing your expected rewards. So if you think about this scenario, the worst possible thing that you can do in this scenario is to allocate your tests to individuals A and B. Right? That would really minimize your expected reward. So I'm not really saying that what CDC was doing was incorrect at all. But what I mean is that correct understanding of incorrect classification probabilities, along with the potential rewards of identifying positive cases and the potential costs of making incorrect decisions, these are extremely important. And I'm not really sure enough attention was being paid to those things when guidelines were established. Okay, so what I showed you was just a simple example, but you can see maybe you can see one important property here. You will see that regardless of what your parameters are, the optimal policy is so that because of the way that this expected reward function, you can see that it's a linearly increasing function of pi. When Rp is greater than Rn, what will end up happening is, sorry, it's a linearly increasing function if Rp is greater than Rn. Is happening is that you will always want to prioritize people with higher likelihood of having COVID when the expected reward for positive patients is larger than the expected reward for negative ones, for negative individuals. Whereas when it's the opposite, that the reward for negative individuals is higher than the reward for positive individuals, then you will want to give your test to individuals who have the least likelihood of having COVID. And so that's mathematically, it's easy to show, okay? So that you will test the M samples with the highest prior probabilities if Rp is greater than N, and if Rp is less than Rn, to test the M samples with the lowest prior probabilities. Now, again, what do we know about these cost and error rates? I think it's probably not difficult to, well, before, our understanding of the error rates at the time, and even now, it's not clear that testing always giving priority to individuals who have high likelihood of COVID-19 priority. Okay, it's not clear that whether it's the right policy at all. Is something that probably it will change on the circumstances and depending on these rewards and costs more specifically. And those rewards and costs actually can change if you are early in the pandemic versus maybe you are late in the pandemic. These days, for instance, where maybe the disease has already spread. So that estimates should really be key in determining how to determine the prioritization policy. In terms of the error probabilities, I'd say that they are easier to estimate because you obviously use these tests repeatedly and you have a lot of data on that. So for any test, that you should probably have a good understanding of what the tests are. Okay, so given that I think I have about like 5 minutes left, let me maybe more quickly talk a little bit about what other things that we can look at. So, when I ask you the question of when you first looked at the simple example individuals with COVID probabilities ranging from 0.6, 0.9, one of you pointed out that 9 is too high. Why kind of our resources on that? Great point. And my result that I showed you didn't seem to be bothered with that. It just said that if the reward is higher for positive people, then you would want to actually give your test to people who really have a probability of having corona, right? But basically there, we ignored the possibility that you could actually treat those people as if they are positive, right? So we basically forced the mathematical optimization so that in order to be able to gain this reward or to say something about this person, that you had to test it, right? But you can easily see that if this person is really very, very likely that the person has positive, maybe we should treat that person as COVID positive, so right, and not waste the test on that particular patient. And similarly, if this person is very, very coronavirus, so maybe that we should not rule out those individuals to begin with. So we kind of extended this model to a setting where you can also label these samples with a presumed result. So essentially, let's suppose that you have the option to label these individuals as presumed positive or presumed negative, only based on their prior practice. Okay, and so what does this really mean in practice? Obviously, you're not testing these individuals that you are positive without testing them, or you are telling you are negative without testing them, but you are taking actions presuming that that person is positive, right? Or maybe you're saying this person that, well, okay, we need to treat you because you have severe symptoms. So it doesn't really matter whether you have coronavirus or not. Or you have 19 because you are really very likely to have so we cannot test you right now because of our limited testing capacity, but this is the action that we need to be taking. So, and when we have that, I think you have looked at the paper a little bit. There are kind of mathematical results there, but I'm not gonna go into the details of that. Essentially, then you could classify the patients according to their prior probabilities in a way that, okay, so in the example that we looked at, let's say that these are two threshold levels. If somebody is, let's say, has a prior probability of smaller than 0.0625 of not having COVID-19, then, and if you choose to if you do not test that person, then you will test that person as presumed negative. And a person who would have a higher probability of coronavirus that is higher than 286, you would classify that person as being presumed positive. So you okay, again, there are these details in the paper, so I'm not going to go into all that. But one thing that I would like to just go all the way to the end, and we have some results on pool testing as well. But I'm going to go all the way to the end. I wasn't expecting to go all this through anyway. But yeah, so this question of prior probabilities PI. So the assumption was that in the optimization model that we know these prior probabilities. Do we really know them? Well, we don't really, right? So nobody knows the prior probability of somebody having a coronavirus, if it's a healthcare worker or if it's a person who has just traveled a high-risk country or who is having this particular type of symptoms. We don't exactly know, but we can rank them based on symptoms and epidemiological history. And this is actually what CDC was doing with the recommendations that it was making, right? And one thing that is nice about the results is that the results do not really depend on individual estimated probabilities, but their ranking of. And so you would test the ones that are higher likelihood of having coronavirus. So that's something that we look for in when we try to prove results. So this is a simplified model, so it will not be realistic to assume that you would know these PIs, but maybe something in the structure of the optimal policy maybe tells you something useful, policy that you might want to adopt in practice. Okay, so I'm mindful of the time, so I'm just gonna stop here. Thank you all.
Thank you, Dr. Ziya. Can we put our emoji hands as we do? I need to let people go on to their next classes, but I wanted to mention a few things. Dr. Ziya has office hours, so if you have questions, I would write them down and I would go to his office hours. Our discussion group also put together a short list of questions, and I'll work with Dr. Ziya to try to get responses to those and put them up on the Sakai site. I also need to mention real quick for all of you, our next talk is another one of those full campus webinar talks like Dr. Crystal Donnelly that we had. So look out for that special link for next week's class. It won't be this link. But besides that, thank you again, Dr. Ziya. And
let me just apologize. I think I messed up time. I thought I had time, but I now realize that that's the end of the time. So
it's so fun. It was very interesting, and we'll make sure to get any residual questions answered.
All right, sounds good.
All right, thank you, everyone.
Thank you.